Okay. Oh, welcome back to another study stream. We have a little bit of a late start today because we had Foundations of Success class and then, well, I was gonna wake up at 10 and then I snoozed like a good 5 times, as usual. Anyways, let's see what the plan today is. So we'll probably get through, we're gonna watch today's content. So that's 2 Pathoma videos and then 2 sketchies. Then I'm gonna set a time limit on how long I'm going to work on cards. So let's say for the remainder of the day, half of it should be spent on what, kiddo? Kiddo want cuddles? He's so needy this morning. Come here. Come. Come on. Come on. Jump up. Come on, baby. Kiddo. Cuddles? Yes? Come on. Come here. He's just staring at me. Okay, guess he changed his mind. What the hell was I saying? Oh, so rest of the day, half making new cards, so reviewing content, and then I'll do the second half active recall, so flashcards or I don't know about you, world, something like that. But anyway, let's just get through the content because this is the most boring part. Okay, I need to wait for Kuro to make up his mind where he wants to be. Kuro, you want to lay my lap? Come here. There you go. He's making his biscuits. Okay. Let's go.
The last of the leukemic processes that we're going to discuss are the myeloproliferative disorders. In order to understand the myeloproliferative disorders, we've got to go back to normal hematopoiesis. So recall that in normal hematopoiesis, there is a CD34 positive stem cell, and that stem cell can produce a myeloid stem cell or a lymphoid stem cell. The myeloid stem cell will eventually become the cells of the myeloid lineage, producing red blood cells, granulocytes, monocytes, and megakaryocytes. And the lymphoid stem cell has the ability to eventually produce the B cells and the T cells. If there is an accumulation of precursors of the myeloid lineage, then we call that acute myelogenous leukemia. If there is an accumulation of cells of the immature lymphoid lineage, then we call that ALL. If there is a accumulation of mature lymphoid cells, for example, T cells or B cells, then we would call that chronic leukemia, and there are subtypes that we've already discussed in the previous section. Now, if there is a neoplastic accumulation of mature myeloid cells, then we call that a myeloproliferative disorder. And of course, the myeloproliferative disorders will be subcategorized based on which cell is predominantly produced. So, for example, if the red cells are overproduced, we call that polycythemia vera. If the granulocytes are overproduced, we call that CML, or chronic myelogenous leukemia. If the megakaryocytes are overproduced, or the platelets of the megakaryocytes are overproduced, we call that essential thrombocythemia. And so this is the general paradigm of the myeloproliferative disorders. Now, I'd like to make one thing very clear before we move forward, and that is that in a myeloproliferative disorder, you actually get neoplastic accumulation of everybody. So everybody's increased. The red blood cells will be increased, the granulocytes will be increased, the platelets will be increased. However, we name it based on the predominant cell. So for example, if there's an increase...
Wait, am I on the right video?
Welcome back. Now that we've completed our discussion of leukemias, we can now address lymphadenopathy includes... Welcome back. Now that we've completed our discussion of leukemias, we can now address lymph nodes. And the first topic that we're going to discuss is lymphadenopathy. Lymphadenopathy refers to enlarged lymph nodes, and it's important to note that lymphadenopathy can be painful or painless. Painful lymphadenopathy is usually seen when there's acute infection and the lymph node is draining that region of infection. For example, let's say that the patient has a strep throat. The lymph nodes in the neck will then be enlarged and they will be painful. So that would be called painful lymphadenopathy. At the same time, it is also possible to develop a painless lymphadenopathy, and the differential diagnosis for painless lymphadenopathy includes chronic inflammation. So for example, autoimmune diseases often have painless lymphadenopathy associated with them. Metastatic carcinoma, if carcinoma spreads to a local lymph node, it's usually painless enlargement of the lymph node that occurs. For example, if a woman has breast cancer and it spreads to the axillary lymph nodes, the axillary lymph nodes become enlarged, and that's usually painless. And the third circumstance in which we can get painless lymphadenopathy is lymphoma. So when we think about painless lymphadenopathy, we really have three major differential diagnoses in our mind: chronic inflammation, metastatic carcinoma, or lymphoma. Okay. We're going to cover lymphoma in much more detail in just a few slides. However, when we have a reactive lymphadenopathy, meaning that the lymph node is big due to some chronic inflammation or reactive process, it is important to note that there is going to be hyperplasia of differing regions of a lymph node depending on the underlying etiology. For example...
You paused my damn video.
If the patient has rheumatoid arthritis, it's classic for there to be expansion of the follicles, and it's this expansion of the follicles that would lead to enlargement of a lymph node. Similarly, in early HIV, there's also expansion of the follicles, and again, it's expansion of the follicles that results in the generalized lymphadenopathy that's often seen in early HIV. Now recall that HIV infects CD4 positive cells, and of course the most important and classic infection would be of the CD4 positive T cells. However, the cells in the follicle, the follicular dendritic cells, they also are CD4 positive. And that's why you see this follicular hyperplasia in early HIV. The paracortex is the region where the T cells live, and so it's pretty straightforward for us to understand that with viral infection, the paracortex would become expanded, and it's expansion of the paracortex that leads to lymphadenopathy. The classic example would be infectious mononucleosis. Recall that in infectious mononucleosis, an EBV infection results in enlargement of the lymph nodes, and that's going to be due to paracortical expansion of the lymph node. And then finally, we can see enlargement of the lymph node due to expansion of the region where the histiocytes live. And of course, the histiocytes live deep in the sinus, in the medulla of the lymph node. And this is classically seen when there is a lymph node that is draining a region of cancer. Let's say that a woman has breast cancer and there are some lymph nodes that are draining that region. Well, it would be classic to see sinus histiocytosis in those lymph nodes. Now, of course, the cancer hasn't gone to the lymph node in this case, but this lymph node is simply becoming reactive because it's draining a region of cancer. And so that's another classic cause of lymphadenopathy. Here's a picture of a lymph node just to remind ourselves of the normal architecture. Up here would be the cortex. Underneath the cortex is the paracortex, and in this region is the medulla. Now, of course, the cortex is where the B cells live. The paracortex is where the T cells live. And the medulla, can you see these lighter pink areas here? This is where the sinus histiocytes live. And so these are the three major regions of the lymph node. Of course, we'd see follicular expansion in the cortex with rheumatoid arthritis and early HIV. We'd see expansion of the paracortex with viral infections. And again, we would see expansion of the medullary region when we had a lymph node that was draining a region of cancer. Now, I put this here in your text and in this discussion because it's often that examiners like to ask about which region of the lymph node is expanded based on a particular etiology. So that's a relatively short section, and now we're going to move into lymphoma. And basically, the very first principle that I'd like to establish is that lymphoma is a neoplastic proliferation of lymphoid cells that forms a mass. Lymph, i.e. lymphoid cells, oma, that forms a mass. And that's what gives it its name of lymphoma. Now, lymphoma can arise within the lymph node, and that makes sense because that's where lymphocytes normally live, but it can also arise within extranodal tissues outside of the lymph node. When we think about lymphoma generally, we should remind ourselves that lymphoma can be divided into non-Hodgkin's lymphoma, which is the more common type, and Hodgkin's lymphoma, which is still relatively common. We will talk in more detail about Hodgkin's lymphoma a little later on, and so at this point what I'm going to do is simply focus on the non-Hodgkin's lymphomas. When we think about the non-Hodgkin's lymphoma, we can classify them based on several parameters. These include cell type, for example, B cell versus T cell, cell size, for example, small cells or intermediate cells or large cells, pattern of growth, for example, do the cells grow in a diffuse sheet or do they form follicles, just as an example, expression of surface markers, in particular, which would help us to determine whether the cells are B cells or T cells, and also cytogenetic translocations. Now, classically, when you think about non-Hodgkin's lymphoma, there have been multiple classification schemes, and I don't want to go into the nitty-gritty in details, but I'll just simply tell you that I think about Hodgkin's lymphoma in a rather simplistic manner. It's probably not the most accurate way if you were a hematopathologist or a hematologist, but I do think that it is an easy way to understand a very difficult concept. And so what we're going to do is I'm going to sort of base my division of non-Hodgkin's lymphoma on cell size. Now, in our discussion, we're going to be focusing on the B cell types of non-Hodgkin's lymphoma, which are the vast majority of non-Hodgkin's lymphoma. So we're going to base it on cell size, and part of that discussion will also be based on pattern of growth, but this will become clear just in a moment. So let's go to a whiteboard and remind ourselves that really when you think about cell size, lymphocytes, when they're neoplastic, can be small, can be intermediate, or can be large. And when the lymphocytes are small, we would think about those as well differentiated. In other words, small lymphocytes that are neoplastic are well differentiated. They look just like, very similar to normal lymphocytes. So they're going to do, on occasion, when they grow, they're going to grow in the patterns in which normal lymphocytes grow. Let's go back and remind ourselves of the normal lymph node. Remember that we're focusing on B cells, and so the normal B area of the lymph node is the cortex. And in the cortex, you have something called the follicle. That's the follicle. And around the follicle is the mantle. It's a dark area that surrounds the follicle. This is called the mantle. And then outside of the mantle, on occasion, not always, but on occasion, we'll actually have generation of something called the margin. So these are the normal zones of the B area of the lymph node: follicle, mantle, and margin. And when we think about cells that are small, that are neoplastic, they basically produce structures that are very similar to the normal lymph node. So we can have a follicular lymphoma that's going to produce a bunch of follicle-like structures. We can have expansion of the mantle zone by neoplastic cells, which is called a mantle cell lymphoma. Or we can have expansion of the marginal zone by neoplastic cells, which is called a marginal zone lymphoma. And these are the three key lymphomas that arise from small neoplastic B cells. There is a fourth one, which I'm not going to discuss here, which we've already discussed, and that's small lymphocytic lymphoma. And recall that that is when CLL involves the lymph nodes. But basically here, I'm going to focus on follicular lymphoma, mantle cell lymphoma, and marginal zone lymphoma. Follicular lymphoma is a neoplastic proliferation of small B cells. Those B cells would be CD20 positive. CD20 is a key marker for B cells. And these small B cells are going to make follicle-like nodules, hence the name follicular lymphoma. Clinically, it presents in late adulthood and usually with painless lymphadenopathy. Now, lymphadenopathy refers to enlargement of the lymph nodes, and these patients will have generalized lymphadenopathy throughout the body that is painless. Here's a picture of follicular lymphoma, and what we can appreciate here is that we're dealing with a lymph node, and we see that the lymph node basically contains dozens of these follicles. So these lymphocytes are making follicle-like structures, hence the term follicular lymphoma. One of the important findings in follicular lymphoma is that it is driven by a translocation of 14/18. Important to remember and very high yield. That what's happening here is that if this is 14, normally in a B cell, on chromosome 14 at this particular locus is immunoglobulin heavy chain. And what translocates with immunoglobulin heavy chain in follicular lymphoma is a gene called BCL2. BCL2 happens to be on chromosome 18. And so this 14/18 translocation pushes BCL2 into the position where immunoglobulin heavy chain was once sitting. Now, immunoglobulin heavy chain gene is a highly active gene in B cells. And so BCL2, when it gets translocated here, becomes highly active and becomes overexpressed. How does that create a follicular lymphoma? Let's recall that BCL2, its role is to stabilize the mitochondrial membrane. And by stabilizing the mitochondrial membrane, it prohibits cytochrome C from leaking from the mitochondria into the cytoplasm, and that blocks apoptosis. Most cells in the human body, they express BCL2 because you don't want apoptosis to occur and you want to hide away cytochrome C. However, in the follicle of the lymph node, that's the that's the particular place in the human body where you actually want apoptosis to occur. Why? Well, what's normally going on in the follicle? In the follicle, you get somatic hypermutation of the B cells. The B cells come in, and they are challenged by antigen, and they undergo somatic hypermutation to see whether they can bind or produce antibodies that are going to bind against that antigen. If they pass somatic hypermutation, they then go from the germinal center, and they can then participate in inflammation. However, if they fail somatic hypermutation, which the vast majority of B cells do, then they undergo apoptosis. And when they undergo apoptosis, that allows them to die. Now imagine if there's a translocation of the B cells so that BCL2 is overexpressed, then those cells that should have died in the follicle actually won't be able to die. And that's then going to result in a follicular lymphoma. So because we need apoptosis in the follicle and we aren't able to undergo apoptosis due to the high BCL2, a follicular lymphoma will develop. And that's what I'm highlighting here in your slide, where I say that it's driven by a 14-18 translocation, and that involves BCL2 on chromosome 18, which translocates to the immunoglobulin heavy chain locus on chromosome 14. Again, overexpression of BCL2 then inhibits apoptosis. These patients are relatively asymptomatic, and they live for a long period of time with this disease. Treatment is usually reserved for patients who are symptomatic, and one way by which we could treat is to give low-dose chemotherapy. Another way would be to give a drug called rituximab, which is an anti-CD20 antibody. So this is another way by which we could treat follicular lymphoma. The complication of follicular lymphoma is that it can progress to a diffuse large B-cell lymphoma. So over time, it could actually pick up additional mutations, resulting in a diffuse large B-cell lymphoma, and this would present as an enlarging lymph node. Now recall that patients with follicular lymphoma, they have generalized lymphadenopathy, where they have multiple lymph nodes in their body that are enlarged. If all of a sudden, one of those lymph nodes begins to become further enlarged, begins to grow more, then we think about progression to diffuse large B-cell lymphoma. It is very important for the purposes of both clinics as well as board exams to distinguish follicular hyperplasia from follicular lymphoma. Now, what do I mean by that? If a patient gets an infection, it is possible that they could get hyperplasia of the follicles just as a result of that infection. And so we need to, when we see a bunch of follicles within a lymph node, we need to be able to distinguish, is this due to follicular lymphoma, which is neoplastic, or is this simply a reaction to an infection? Now, how could we do that? Well, number one, when we have follicular lymphoma, there'll be disruption of the lymph node architecture. What do I mean by that? Well, I'm going to take you back a couple slides to this picture which I have drawn you here, and let's look at this lymph node again. When we look at this lymph node, what we see is that there are follicles throughout the entire lymph node, and we don't see any other structures. So these follicles have basically taken over or disrupted the normal lymph node architecture, and that's an indication that we're dealing with follicular lymphoma. If this was a follicular hyperplasia in response to an infection, we would see expansion of the follicles, but all of the follicles would be present in the cortex where the follicles normally live. The fact that these follicles are destroying the lymph node and going deep into the lymph node is an indication that we may be dealing with a follicular lymphoma. The second important feature concerning the distinction between hyperplasia and lymphoma is a lack of tingible body macrophages in the germinal center. This image here is meant to highlight that. Now let's remind ourselves that when we have infection, then we're going to get a follicular hyperplasia, and that follicular hyperplasia occurs because B cells are coming into the follicle, they are undergoing somatic hypermutation in the follicle, and as a result of somatic hypermutation, many of them are dying. Now, if the B cells in the follicle are truly undergoing somatic hypermutation and dying via apoptosis, then recall that the response to apoptosis at the very end is that the macrophages come in and they clean up the dead cells. And so if we have a follicle that is reacting to infection, we should see a ton of macrophages present within the germinal center. And that's what these little white spaces here represent within this germinal center. So why don't I take you back a step and show you that this is the germinal center. This darker blue area here is actually the mantle surrounding the germinal center. And within this germinal center, we see these white spaces, which indicate that macrophages are present and are eating the debris of apoptotic cells. These macrophages are also called tingible body macrophages. And they indicate, again, that apoptosis is actively occurring within the germinal center. Now let's contrast that against follicular lymphoma. Here's the follicle of follicular lymphoma. Do you see any tingible body macrophages in that follicle? The answer is no. We don't have those nice tingible body macrophages in the center of that follicle, and that's because these cells are not undergoing apoptosis. They have undergone a 14-18 translocation. BCL2 is overexpressed, and the overexpression of BCL2 is actually blocking apoptosis in these cells. And that's an important point concerning follicular lymphoma. A third important point concerning follicular lymphoma is the expression of BCL2 in the follicles. The vast majority of cells in the human body, they express BCL2, and that's because you don't want those cells to undergo apoptosis. However, in the follicle, in a normal follicle, in you and I, there would be no expression of BCL2 because you want to turn BCL2 off to allow for apoptosis. But if there is expression of BCL2, that would indicate that we're dealing with a follicular lymphoma. The final way by which we can make this distinction is monoclonality. Recall that if we have a reactive proliferation of lymphocytes, and this goes back to our discussions of neoplasia, if you have a reactive proliferation of lymphocytes, it would be polyclonal. And if we have a neoplastic proliferation of lymphocytes, it would be monoclonal. And of course, clonality is gauged in B cells by looking at the ratio of kappa to lambda light chain. In a polyclonal reactive proliferation, the ratio would be 3:1, whereas in neoplasia, the ratio would be disrupted. For example, classically on an examination, 20:1 or 25:1. So that is follicular lymphoma. Now we come to mantle cell lymphoma, and mantle cell lymphoma is when you have a neoplastic proliferation of small B cells, obviously CD20 positive, that expand the mantle zone. This clinically also presents in late adulthood and also presents with generalized painless lymphadenopathy. Now, when you have this type of tumor, one of the classic descriptions on examination is that the examiners could tell you that there is a neoplastic proliferation of cells that expands the region immediately adjacent to the follicle. If you have a tumor that expands the region immediately adjacent to the follicle, that region is obviously the mantle, and so that would be a mantle cell lymphoma. So that's a nice way that examiners might try to describe the tumor. This tumor is driven by an 11-14 translocation. Well, what's on 14? Immunoglobulin heavy chain. What gets translocated to that spot? Cyclin D. That's the key gene that's going to drive the production of mantle cell lymphoma. Now recall that cyclin D is a cell cycle regulator. It helps the cell to go from G1 to S phase, and the way that it does it is by phosphorylating proteins. So a high level of cyclin D would actually phosphorylate the regulators, allowing the cell to go from G1 to S phase. And this is important for examination purposes. You need to know that cyclin D causes the cell to go from the G1 to S phase. And this is a key translocation in mantle cell lymphoma. The third lymphoma that would produce structures similar to the normal lymph node is a marginal zone lymphoma. So what is the marginal zone? The marginal zone is that region which is outside of the mantle. Here's a lymph node again. This is the follicle. Outside of the follicle would be the mantle, and outside of the mantle would be the margin. And so we could develop a tumor that expands the marginal zone, and that's called a marginal zone lymphoma. Again, it's usually due to neoplastic B cells that are going to be CD20 positive. Important to know that this type of lymphoma is associated with chronic inflammatory states. This kind of goes back a little bit to normal immunology, because remember that most lymph nodes don't have a marginal zone. The marginal zone is actually formed by when there is activation of the cells through the germinal center. And so when cells go into the germinal center and get activated because of, for example, chronic inflammation, that's when the margin is produced. And so the marginal zone would be classically seen, I should say, when there's chronic inflammatory states. So what are some associated disorders? In Hashimoto's thyroiditis, patients can develop a marginal zone lymphoma as a complication years later. In Sjogren's syndrome, as I've already described in the immunology lectures, we can develop a complication of marginal zone lymphoma, and the idea here would be that the patient presents with unilateral enlargement of the parotid years into her Sjogren's syndrome. And then another classic one is H. pylori gastritis. Now in H. pylori gastritis, what happens is that you get a marginal zone lymphoma in mucosal sites, and that's also called a maltoma. And again, the gastric maltoma in the mucosa of the stomach can possibly regress if the H. pylori is treated. And so maltoma, mucosa-associated lymphoid tissue mass, is one of the subtypes of marginal zone lymphoma. Now that concludes our discussion of the small B cell lymphomas that mimic normal structure of the lymph node. And so we're going to move now to a tumor in which we have intermediate-sized B cells. Of course, they're CD20 positive because they're B cells, and this is called Burkitt lymphoma. So Burkitt lymphoma, intermediate-sized B cells that are CD20 positive. There is an association with EBV. Classically, this tumor presents as an extranodal mass in a child or young adult. There are two forms. It's the African form, which produces a jaw mass, and there's a sporadic form, which involves the abdomen. One of the ways by which examiners like to go after this is they show you a picture like this, and when they show you a picture like this, they are trying to have you recognize that this is an example of Burkitt's lymphoma of the jaw, and then you could potentially be asked, well, where would the where would the sporadic form arise? And the sporadic form arises more commonly in the abdomen. The African form more commonly arises in the jaw. Very important to know about these tumors that they're driven by translocations of c-MYC. c-MYC is present on chromosome 8. The most common translocation is an 8:14 translocation. In this particular case, c-MYC gets translocated to the immunoglobulin heavy chain locus on 14, and that results in overexpression of c-MYC. Now, c-MYC is a nuclear regulator that activates multiple genes necessary for promotion of growth. And so when you have a lot of c-MYC, you're going to have a lot of growth, and that is then going to drive production of the tumor. So most important to recognize that it's c-MYC that drives production of this tumor. This tumor is so rapidly growing it has a very high mitotic rate, and that rapid growth results in a starry sky appearance on histology. Let me explain that a little further. Here's the histology, and these cells, all of these circular blue cells, these represent the tumor. And so they call this the sky. The blue represents the sky. And then here, some of the cells are turning over so quickly that they're actually dying, and these are macrophages, i.e. tingible body macrophages, that are present within the tumor and are eating away the cells as they die. They're growing so fast that they die. So that is the star. So the blue represents the sky, and this what?
See, that's purple, not blue. I wonder why they call that blue. That's literally purple, or am I tripping? That looks so purple to me. Like, that's straight up purple. I'm gonna get a color picker on this thing. Color picker.
White area represents the star.
Oh my god, Goodo! Goodo, there's no space for you, honey. I'm sorry. Okay. I mean, it's like, it's purple, but on the bluish side of things. Like, I don't know if you see this, girl, but on the color scale, it's like closer to pink than it is to blue. I guess scientists are just colorblind. Oh, okay. Anyways.
And the classic, again, description is a starry sky appearance. So that takes care of the intermediate sized lymphoma of B cells. Now we come to the lymphoma in which there are large B cells. And this is called diffuse large B-cell lymphoma. Diffuse, it doesn't produce follicles, it doesn't produce a margin, it doesn't produce a mantle, it grows diffusely. Large, the cells are large. B, the cells are B cells, and hence they're CD20 positive. And of course, this is a lymphoma. So that's the summary of diffuse large B-cell lymphoma. It's the most common form of non-Hodgkin's lymphoma, and it's clinically very aggressive. It would make sense that it's clinically aggressive because it's not well differentiated. It doesn't look like normal structure. It doesn't have small B cells. And so because it's poorly differentiated, we would expect it to be clinically aggressive. Now, diffuse large B-cell lymphoma can arise sporadically, or it can arise from transformation of follicular lymphoma.
Oh my god.
And I've already explained that in detail when we talked about follicular lymphoma. This tumor presents in late adulthood, usually as an enlarging lymph node or as an extranodal mass. Once you've understood non-Hodgkin's lymphoma, you can now then move to Hodgkin's lymphoma. And Hodgkin's lymphoma is not too difficult to understand. Basically, the notion in Hodgkin's lymphoma is that instead of having a whole mass of malignant cells, so for example, in a non-Hodgkin's lymphoma, the entire mass is composed of malignant cells. Well, in a Hodgkin's lymphoma, you don't have a big mass of malignant cells. Instead, you have rare neoplastic cells called Reed-Sternberg cells, and those Reed-Sternberg cells secrete cytokines that draw in other inflammatory cells, which then results in production of a mass. And so the key hallmark of a Hodgkin's lymphoma is a Reed-Sternberg cell. The Reed-Sternberg cell is a large B cell, classically with a multi-lobed nucleus and a prominent nucleolus. And often, and usually, most commonly, they are CD15 and CD30 positive. Notice that there is no CD20 expression here, although it's clearly a B cell. They are CD15 and CD30 positive. Now here's a picture of a Reed-Sternberg cell. I put one here in the center. This is a large cell. It has a multi-lobed nucleus. Here's one lobe, here's another lobe. We can clearly see this nucleolus, this darker purple area, and this kind of gives the appearance of owl eyes, and so it's also called an owl-eyed nucleus. So that's a Reed-Sternberg cell. Now notice that there's one Reed-Sternberg cell, but that there are then hundreds of other cells that are sort of joining the party, and those are reactive cells. But it's the Reed-Sternberg cell along with all of the reactive cells that's actually producing the mass, and so that is going to be classic for a Hodgkin's lymphoma. Now, in the Reed-Sternberg cells, they secrete cytokines, and when they secrete cytokines, that's going to result in a few things. Number one, a subset of these patients can present with B symptoms. B symptoms are like fever, chills, and night sweats, and it's actually due to the cytokines being produced by the Reed-Sternberg cells. In addition, those cytokines are going to attract lymphocytes, plasma cells, macrophages, and eosinophils, which are then going to cause the actual mass to form. So the bulk of the tumor, the bulk of the mass in this disorder is actually reactive cells. Also, fibrosis may be present, and you'll see why that's important in a moment. As I've already stated, the reactive inflammatory cells make up the bulk of the tumor, and they also form the basis for classification. So that the subtypes of Hodgkin's lymphoma include, number one, nodular sclerosis. This is the most common, and I'll explain it in more detail in a moment. There's a lymphocyte-rich variant, where there's a ton of lymphocytes that are associated with the Reed-Sternberg cell. There's a mixed cellularity variant, where there's mixed cell type that's associated with the Reed-Sternberg cell, especially eosinophils. And there's a lymphocyte-depleted variant, which actually has minimal lymphocytes associated with the Reed-Sternberg cell. The most common subtype, as I've already explained, is nodular sclerosis subtype. The classic presentation in nodular sclerosis subtype is that the patient has an enlarging neck lymph node or an enlarging mediastinal lymph node and is usually a young female. Biopsy is then performed, and the biopsy reveals a lymph node that is divided by broad bands of fibrosis. And this is the classic histology on low power. This is a picture of a lymph node, and you can see that there's these broad pink bands of fibrosis, as I'm outlining here, and these broad pink bands of fibrosis are cutting the lymph node into these nodules. And so that's nodular sclerosis subtype. Remember that the word sclerosis just means hard, and it's hard because it's got all this fibrotic tissue within it. At the same time, one of the classic findings on histology is that the Reed-Sternberg cells in this particular subtype often sit in these big open spaces. So notice that we've got this big open space with a Reed-Sternberg cell in it, another big open space with a Reed-Sternberg cell in it. And so these spaces look like lakes. And so they're given the name lacunar cells. And lacunar cells are a special kind of Reed-Sternberg cell that is present in nodular sclerosis subtype. The other subtypes are not necessarily super common, and it's often difficult to remember them, but I'll just tell you a few important principles. Number one, the lymphocyte-rich has the best prognosis. Number two, the lymphocyte-depleted has the worst prognosis. So the more the lymphocytes, the better, the less the lymphocytes, the worse. And the lymphocyte-depleted happens to be seen in the elderly and in HIV-positive individuals. One final principle is that in the mixed cellularity variant, you see abundant eosinophils. And very important to know for examination purposes that those abundant eosinophils are being called in by IL-5. So the Reed-Sternberg cell is overproducing cytokines, for example, IL-5, and it's IL-5 that draws in the eosinophils. In these patients, there may also be an eosinophilia, where they have extra eosinophils in the blood, and that's also due to increased IL-5 production by the Reed-Sternberg cells. And that closes off our discussion of lymphoma. Not too difficult if you just keep sort of the big picture in mind as you go through them. Our next discussion will be plasma cell disorders.
Okay, wow, 30 minutes. We did that. Plasma cell disorders and histiocytosis is next. Oh my God, staying inside for like multiple days in a row. I've done this before. I remember during my gap year, there was one time I stayed in my apartment, never left for like 2 weeks straight, and I was extremely depressed. And this is bringing me back to that time. It is tough. I feel like having a change of environment is very important for, like, I don't know, feeling like you have some sort of routine, or like feel active in a way. If you're just in the same space for a week straight, it feels extremely like suffocating and boring. Just boring. No motivation. Like, where am I supposed to find the motivation to study or do anything productive when I literally can't leave this space? And like, no matter how comfy my apartment is, it's very distracting, and like, I can't really focus at home much because of the cats. Like, I know I can go into the office, like that's why I have an office, to study, but I feel like I'm just more comfortable working outside in the living room. And also in the office is just like extremely cold. Like, I don't know why, but the extreme temperatures are always in the office room. So it's either really cold in there or really hot in there. Like, if I turn the heat up to make it not as cold, it'll get super hot in there. So either I'm like freezing or I'm like sweating in that room. There's like no in between ever. I was thinking of going to Starbucks because I called them earlier and they said they were going to be open till 5. But like, that would only give me like a short amount of time to study there, and then I would have to go back, and then I just don't know about driving in this weather. So anyways, we go next.
Welcome back. This is the last video for chapter 6, and in this particular discussion, we're going to cover both plasma cell disorders and Langerhans cell histiocytosis. Now, plasma cell disorders are also called plasma cell dyscrasia, and dyscrasia basically means disorder. Plasma cell disorders are a broad spectrum of disorders. The prototypical example is multiple myeloma, and so we'll start with multiple myeloma. Multiple myeloma is a malignant proliferation of plasma cells. It's the most common primary malignancy of bone. Overall, the most common malignancy to involve bone is actually metastatic carcinoma, but notice here that we're saying the most common primary malignancy of bone. One of the important features that drives the production of these plasma cells is serum IL-6. IL-6 is often elevated in these patients, and IL-6 is an important growth factor for plasma cells. And because it's an opportunity for examiners to tie in immunology with pathology, IL-6 often shows up on exams as well, especially in this context. Now, when we have a neoplastic proliferation of plasma cells, the clinical problems are all going to be based on what the plasma cells are actually producing. For example, the plasma cells have the ability to produce osteoclast activating factor. Osteoclast activating factor. And when it produces osteoclast activating factor, the osteoclast will get activated. Of course, the osteoclast, they eat away at bone, and so that'll result in punched out lesions that will be seen on x-ray, particularly in the vertebra and the skull. Now, those punched out lesions will result in bone pain, and that will also produce hypercalcemia, because as you punch out the bone, calcium will be pushed into the serum. And there's also going to be an increased risk of fracture, because when you punch out the bone, that's going to weaken the bone, increasing the risk for fracture. So I would probably summarize this slide by just remembering that the plasma cells produce osteoclast activating factor, which, by the way, go back to biochemistry, activates the osteoclast via the rank receptor, and that then subsequently is going to create all of the problems of bone that we are so classically used to identifying. For example, this is an x-ray, and we can clearly see that there are these circular regions of punched out bone on this x-ray, highly associated with multiple myeloma. Now, in addition, the plasma cells of multiple myeloma will produce immunoglobulin. And when they first produce immunoglobulin, there will be an elevated serum protein. When you have a patient that has an increased serum protein and you can't determine the cause, one ancillary test that's particularly useful is called a serum protein electrophoresis, or an SPEP, serum protein electrophoresis. Now, the way this works is that if this is the gel, as you run the serum on a gel, you'll develop certain bands. For example, the most abundant protein in the blood is albumin, so there'll be an albumin band. There's an alpha-1 band, an alpha-2 band, a beta band, and also a gamma band. Now, this gamma peak here, this represents the gamma globulins, and this peak is usually wide, and it's not as high as the albumin peak. So this is a normal serum protein electrophoresis, roughly. And of course, the gamma globulins include IgG and IgA and IgE, etc., IgM, etc. Now, in a patient who has a multiple myeloma, they have a tumor of plasma cells, and the plasma cells are going to overproduce immunoglobulin, so that when you run this serum protein electrophoresis, you're going to see a very sharp spike in the gamma region. And this sharp spike, this is called an M spike. Now, important to note that the M spike indicates monoclonal immunoglobulin. M spike does not mean that it's IgM. It just means that you have a monoclonal immunoglobulin. Notice that this band is tight and it's very high. Tight in the sense that it's very narrow, but it's also very high. So this is called an M spike, and again, it indicates monoclonal immunoglobulin. Now, it so happens that when you think about multiple myeloma, the neoplastic cells produce immunoglobulin, and that immunoglobulin would be seen as an M spike on the SPEP. However, it's most commonly IgG or IgA. So that an M spike in multiple myeloma is usually IgG, but can be IgA. One complication of having a neoplastic proliferation of monoclonal plasma cells is that those monoclonal plasma cells are all going to produce the exact same antibody. Now, remember that the goal of the body is to have 1 million different plasma cells that produce 1 million different antibodies. However, if you have one plasma cell that's producing 1 million antibodies, but every antibody recognizes the same antigen, you're going to lose antigenic diversity. And so patients with multiple myeloma, they lose antigenic diversity because they only have one antibody produced from one mother cell, and that's going to result in an increased risk for infection. Infection, in fact, is the most common cause of death in multiple myeloma. Now, another consequence of having too much protein within the blood is that it's going to interfere with the charge between the red blood cells, so that there will be a decreased charge between the red blood cells. And when there's a decreased charge between the red blood cells, when you have a blood smear, instead of the red blood cells distributing themselves equally across the smear, they're going to start piling up on each other like poker chips. And so this is called rouleau formation. And that's, again, a sign of the high serum immunoglobulin in patients with multiple myeloma. Another consequence of multiple myeloma is that the plasma cells, the malignant plasma cells, are going to overproduce light chain. Go back and remind yourself from normal immunology that when immunoglobulin is formed, it's actually formed by both heavy chain and light chain. And it's the heavy chain and light chain that join together to form the immunoglobulin. Normally, the plasma cell would produce an equal amount of heavy chain and an equal amount of light chain so that it can then produce immunoglobulin. However, when you have a multiple myeloma, there's overproduction of light chain often. And the overproduction of light chain results in free light chain that circulates in the serum and eventually deposits in tissues. And when it deposits in tissues, that forms an amyloid called AL amyloid. And remember that AL amyloid is also known as primary amyloidosis, so that these patients can develop amyloidosis. The light chain can also get excreted in the urine, which would then result in proteinuria. And when those proteins are excreted in the urine, i.e. the light chains, that's called Bence-Jones proteins. At the same time, the light chain can deposit in the kidney tubules, which could then damage the kidney, resulting in renal failure, and that's called myeloma kidney. So basically, if we wanted to summarize the problem with the light chain, what we could say is that the light chain goes into the blood and deposits as amyloid, goes into the urine and comes out as Bence-Jones proteins, and deposits in the kidney itself, which results in renal failure. And that is an overall summary of multiple myeloma. And again, the way I think about it is that you've got a neoplastic proliferation of plasma cells, and the plasma cells are overproducing various substances, which then give clinical findings. Substance number 1, osteoclast activating factor. An osteoclast activating factor will then punch out the bone marrow, giving you bone pain and increased risk for fracture, will also create hypercalcemia. Similarly, the plasma cells are going to produce immunoglobulin, giving you a high serum protein with a M spike on serum protein electrophoresis. And also, you're going to lack antigenic diversity because you've only got one cell type that's making all of the immunoglobulin, which is then going to result in an increased risk for infection, which is the most common cause of death in multiple myeloma. And the third complication is that you're going to overproduce light chain, and the overproduced light chain will go into the blood, deposit in tissue as amyloid, go into the urine, come out as Bence-Jones proteins, and can possibly deposit in the kidneys, resulting in myeloma kidney. So I think that's a very easy and straightforward summary for multiple myeloma.
Easy.
Now let's pretend that you see a patient in your clinic, and this patient has a high serum protein. Of course, when they have a high serum protein, you need to explain the cause, and so you do an SPEP, and when you do the SPEP, you clearly see that there is a M spike. Now, once you see an M spike, you start thinking about the possibility of multiple myeloma. So in this patient, you then ask the question, what other findings are there? So you begin to look for lytic lesions, but you don't find them. You look for hypercalcemia, but you don't find it. You look for amyloid, you don't find it. You look for Bence-Jones proteinuria, you don't find it. So when you have an isolated M spike with none of the other findings of multiple myeloma, that is called a monoclonal gammopathy, problem with the gamma globulins, of undetermined significance, i.e. MGUS. And so this is an important plasma cell dyscrasia to be aware of. This is common in the elderly. 5% of patients over the age of 70 have MGUS, and 1% of those patients each year will go on to develop multiple myeloma. So it's almost like a dysplasia or like a pre-myeloma state. Another important disorder to consider in this particular discussion, mostly for the purposes of compare and contrasting, is Waldenström's macroglobulinemia. Now, this is a lymphoma, but it produces monoclonal IgM. IgM is a pentamer. It's a big antibody, and that's why we call this disease macroglobulinemia. It's a big globulin, i.e. IgM. Now, because this is a lymphoma, the patients are going to present with generalized lymphadenopathy. That's what lymphomas do. They go to the lymph node. Lytic bone lesions will be absent. There will be an increased serum protein with an M spike, but instead of being due to IgG or IgA, it'll be due to IgM. And again, this is Waldenström's macroglobulinemia, and that's what we would expect to see, IgM. Now, that IgM is a very big molecule, and it increases the viscosity of the blood. And when it increases the viscosity of the blood, there's going to be a risk for retinal hemorrhage or stroke, and that would be a consequence of this hyperviscosity. At the same time, there's going to be an increased risk of bleeding, and that's because the hyperviscosity leads to defective platelet aggregation, and if the platelets can't aggregate properly, there could be an increased risk of bleeding. When patients have acute complications in Waldenström's macroglobulinemia, you can treat them with plasmapheresis. This is basically removal of the patient's blood, and then once you've removed it, you use a machine to pull out the IgM, and when you pull out the IgM, you'll obviously decrease the risk of the acute complications. So these are a few of the plasma cell dyscrasias, and again, we don't want to go into extensive detail here, but I think you understand the prototypical diseases, and that's what's key to know for basic clinical practice as well as examinations. The next and final section of Chapter 6 is Langerhans cell histiocytosis. Langerhans cells are specialized dendritic cells found in the skin. They're derived from bone marrow monocytes, and they present antigen to naive T cells. A tumor of Langerhans cells is called Langerhans cell histiocytosis. This is a neoplastic proliferation. Characteristic of these cells is that the cells often have Burbeck or tennis racket granules, which can be seen on EM, and also the cells are classically CD1A positive and S100 positive by immunohistochemistry. So here's a tennis racket granule, and this obviously is the tennis racket from the 1960s. This is not what tennis rackets look like anymore. However, it is a very high yield image to be familiar with. So this is a Burbeck granule, and it's characteristic of a Langerhans cell. Now, when you think about Langerhans cell histiocytosis, it's a relatively complicated discussion because it's hard to remember these, particularly because you'll never probably see them. So there's 3 subtypes, and I have some basic principles that I like to remind students of when I talk about these. Number 1, if the disease is named after someone, the proliferation is usually malignant, all right? If the disease has people's names in it, then it's malignant, and malignant proliferations usually involve the skin. And if there's 2 people's name, it'll usually be seen in children less than 2. And if there's 3 people's name, it'll be seen in children greater than the age of 3, for example. Now, again, these are just silly mnemonics to help us to remember.
Wait. If there's 2 people's names in it, children less than 2. 3 people's names, children older than 2. Is that what he said?
People's name, it'll be seen in children greater than the age of 3, for example. Now, again, these are just silly mnemonics to help us to remember these diseases, but as I walk you through these diseases, you'll see that it'll become somewhat helpful. For example, the first of these is Lederer-Seaway disease. Again, two people's names in the disease, and so it's malignant. And if it's malignant, you're classically going to see a skin rash. And because it's 2 people's names, it'll be in infants less than 2 years of age. So let's read together. Classic presentation is skin rash and cystic skeletal defects in an infant. Multiple organs may be involved, and this is rapidly fatal. Eosinophilic granuloma does not have a name in the disease name, and so therefore it's a benign proliferation. Again, that's my little way of remembering it. The classic presentation is a pathologic fracture because it usually involves bone, usually presents in an adolescent. The skin is not involved, it's benign, so the skin would not be involved. And the biopsy is going to show Langerhans cells with abundant eosinophils, and that's why it's called eosinophilic granuloma. It's important to be familiar with this disorder because especially on examinations and even in the clinics, if you've got a patient with a pathologic fracture, that's an adolescent, for example, they're playing basketball and then they fracture a bone, you would start thinking about osteosarcoma. So it's important to have eosinophilic granuloma on your differential as well. The final histiocytosis that we want to talk about is Hans-Schüller-Christian disease. Again, this has 3 names in it, so we're going to think about it as malignant. Because it's malignant, it's going to involve the skin, giving you a scalp rash, and there can also be lytic skull defects. The patients classically also have diabetes insipidus and exophthalmos, and it's usually seen in a child, classically greater than the age of 3. So these are some silly ways of remembering Langerhans cell histiocytosis. And of course, they're not very common. They're somewhat difficult to remember. And some people might even say they're quote unquote low yield. But anyway, I hope that that's helpful to you in gaining just a very simple understanding of these disorders. And that closes off chapter 6.
Low yield, huh? Okay. Sleepy, sleepy, sleepy. Okay. You can see how long these sketchy videos are. Interferons. What the hell? Hello? Oh. It's being hella slow right now. Okay. Interferons. 10 minutes. Okay, not bad. Then methotrexate. Methotrexate. 29 minutes. Yay! That's crazy, actually. Wowza. Okay, how many symbols are there? Okay, so we're gonna put this into Notability so that I can annotate. Yeah, I was organizing it by day and then I just gave up, so. Here we are. So. The lesson summary first. There you go.
Wait, you...
This is the tedious part. Now that I think about it, I think I would like it more if I just watched the video and screenshot it as I go. Motherfucker. Fuck, I haven't even taken my meds yet. Shit. Okay, you know what? I'm gonna turn the thermostat up. Cause I'm cold. Oh, you know what? And I need to put my clothes in the dryer. This is peak procrastination. Clothes are in the dryer. I guess we'll watch this video.
You guys, we did it!
It's our last sketchy farm unit.
Hey.
You know, it seems like only yesterday we were taking a stroll through that autonomic section. You remember that sketch with the anti-emetic stadium? A preppy ant. I mean, that's just a good mnemonic. Oh, and
I
do you
don't
remember the
remember
creepy
that.
Edgar Allan Poe one? I have no idea what was going on there, but for some reason, I was eerily aroused. Anyway, I hate to
What?
say it, but we're about to wrap up Sketchy Farm, and our grand finale, cancer chemotherapeutic agents. Cancer can be treated regionally through surgical removal or targeted radiotherapy. Chemotherapy, on the other hand, involves the systemic administration of cytotoxic drugs to eradicate or control the proliferation of cancer cells. However, their dispersal throughout the bloodstream means that these drugs reach both cancerous and normal cells alike, leading to significant systemic adverse effects. Compared to slowly dividing cells, however, rapidly proliferating cells like cancer cells synthesize larger amounts of DNA and RNA per unit time. The pathways involved in de novo nucleotide synthesis, therefore, have become attractive targets for the control of rapidly dividing cells. And when I say attractive targets, I mean ridiculously attractive, like Idris Elba attractive. This entire chapter focuses on
don't know what that
antimetabolites,
is.
molecules that exert their anti-proliferative effect by mimicking the intermediates involved in various steps of nucleic acid metabolism. They can masquerade as a purine or pyrimidine, for example, the nitrogenous bases that form the backbone of DNA. This tricks a tumor cell into incorporating these molecules into DNA, leading to strand breaks. Or these drugs work by replacing other key intermediate molecules necessary for the production of new bases, like a folate analog, for example. This clogs up the enzymatic machinery responsible for DNA synthesis, and cell growth is halted. In this sketch, we're going to focus on anti-metabolite drugs that inhibit the enzymatic pathways involved in the formation of thymidine specifically, with special attention paid to agents that affect the folic acid cycle, but we'll get into that in a bit. Thymidine is a pyrimidine deoxynucleotide. Deoxynucleoside just means that it has one of those deoxyribose pentose sugars attached. I know, who cares, right? It's the pyrimidine nitrogenous base we're going to emphasize here. At Sketchy, we depict pyrimidine and purine bases by their molecular structure. Just think back to the acyclovir airport or the ganciclovir market. Purines, such as adenine and guanine, are represented by a hexagonal shape attached to a pentagon. Ganciclovir is a guanosine analog, remember, as depicted by these ganciclovir cans. Pyrimidines, on the other hand, such as thymine, cytosine, and uracil, are depicted by their lone hexagonal structure, like this hexagon plate here on the sushi bar counter. The synthesis of thymidine is catalyzed by thymidylate synthetase. You know, because it synthesizes thymidine. I mean, that's just a good name. You know what I call gloves? Hand socks. Anyway, this enzyme works by methylating
Who
a
writes these
phosphorylated
scripts?
uridine called deoxyuridine monophosphate, or DUMP, and turning it into a phosphorylated thymidine called deoxythymidine monophosphate, or DTMP. Think of it this way. See that hexagonal plate of dumplings? It's hexagonal because it depicts a pyrimidine precursor molecule, and the dumplings are meant to represent DUMP specifically. Once a customer chows down on those DUMP dumplings, it's converted into DTMP, as you can see here. You've got one dumpling left for the D, and then a pair of
Actually, now that I think about it, I keep changing my mind. We're at 4 minutes. I'm just gonna do the rest of these because this gives you more context. Damn it. I actually had a dream about Sketchy. I remember talking to somebody about Sketchy, and I was saying something like, oh yeah, like, low-key I hate watching Sketchy videos, but like whenever I take exams I think back to the Sketchy image and then I can remember like details about it. Like it kind of helps actually. And it does, but the videos are stupid, but they work. But so many videos. And then I start like getting them mixed up in my head, you know, like the mnemonics are good and all, but like eventually it's just, there's just so many images in your head that you get them mixed up and then you're like, wait, was there a cat in that one or was there not? And then I don't know. But it is helpful because so much of med school is like memorizing a shit ton of facts, and it's just so much that you have to use like certain strategies to try to remember all the information. Otherwise it's hard. I make up like the weirdest ways of remembering things too. All right. We are going to annotate. This wants to update, that is. All right.
Chopsticks are set down on the plate, evoking the thymidine T. This whole reaction, turning DUMP to DTMP, is powered by the folate cycle, represented here by the cycle of sushi boats going by. Uridine is methylated to turn into thymidine, so it just needs a carbon, right? Take a look at that incoming boat on the left. It turns out that a methylated tetrahydrofolate provides that carbon. At Sketchy, we represent folate with foliage. So in this scene, tetrahydrofolate is represented by a boat with 4 leaves, probably some Mizuna or something. And that C-shaped sushi represents the carbon available for donation. As the boat floats by, the customer dining on those DUMP dumplings transfers over that carbon sushi to his plate, inadvertently knocking off 2 of the folate leaves as well. Thus, tetrahydrofolate is converted to dihydrofolate and DUMP is methylated to DTMP. This whole process, catalyzed by thymidylate synthase. In order to keep producing more thymidine deoxynucleotides, you need to recycle that folate so it can donate more carbons. In other words, you've got to turn that dihydrofolate back into tetrahydrofolate, and here's how that happens. Stay with me here. Dihydrofolate, represented by the boat with 2 leaves, gets converted back to tetrahydrofolate by the enzyme dihydrofolate reductase. It's a reductase because you're adding 2 hydrogens, so you're reducing it. Notice that tetrahydrofolate is again represented by the boat with 4 folate leaves. Well, tetrahydrofolate is a carbon donor, so let's get that carbon back on it. A methyl group contains a single carbon, so tetrahydrofolate is then methylated, represented by the addition of the C-shaped carbon sushi. Tetrahydrofolate is now ready to donate some more carbons and methylate those deoxyuridine dumplings into some brand new pyrimidine nucleosides. That is, unless you throw our first anti-metabolite agent into the mix, methotrexate. Methotrexate is a folate analog, so it looks like folate, but it's not. It competitively and irreversibly binds to dihydrofolate reductase, preventing the conversion of dihydrofolate into tetrahydrofolate. Think of methotrexate as this methotrexate meat stick chef. He's trying to replace folate like a folate analog, if you will. Instead, he's irreversibly upended that sushi boat and brings the folate cycle to a halt. With dihydrofolate reductase irreversibly inhibited, targeted cells can no longer regenerate tetrahydrofolate, and as you can imagine, the precursors folate and dihydrofolate will build up inside the cell like this traffic jam of dihydrofolate sushi boats. No tetrahydrofolate means no de novo synthesis of that thymidine nucleoside DTMP we keep talking about. And that's not all, because tetrahydrofolate is also involved in the synthesis of purine nucleosides and some amino acids as well. Inhibition of these metabolic pathways interferes with the formation of DNA, RNA, and key cellular proteins inside rapidly dividing cells. Dividing is the key here. Rapidly proliferating cells, such as cancer cells and inflammatory cells, are preferentially inhibited by methotrexate because it's these cells that are producing substantially greater quantities of nucleotides. So, since we're targeting DNA synthesis specifically, antimetabolites like methotrexate and the rest of the agents in this chapter are most effective during the S phase of the cell cycle, the stage when cells are undergoing synthesis of new DNA in preparation for cell division. In fact, many of the anti-cancer drugs in this unit exert their action on cells traversing a specific phase of the cell cycle and are therefore called cell cycle specific. Whenever an anti-proliferative agent is cell cycle specific, we'll be sure to depict that particular stage within the sketch, like in the name of this sushi restaurant here, sushi phase. Also, because these agents prevent the synthesis of DNA, their logo depicts a pair of chopsticks clamping down on that growing strand of DNA-evoking ramen noodles. This is how methotrexate acts as a chemotherapeutic agent. It's a folate analog that halts DNA synthesis in rapidly dividing cells, leading to cell death. It's cytotoxic. I mean, just take a look at this broken cancer crab here, our recurring sketchy symbol for agents with anti-neoplastic effect. Methotrexate can be used in combination with other chemotherapeutic agents to treat a range of malignant conditions, especially leukemias, lymphomas, as well as solid tumors such as breast cancer, head and neck cancer, and lung cancer. Also, because methotrexate causes death of all rapidly dividing cells, it can be used to treat a wide variety of non-neoplastic conditions that are characterized by abnormal cellular proliferation. Just take a look behind our methotrexate chef, where a couple of customers are emptying their backpacks and making off with a few more of those methotrexate meat sticks. I mean, it did say all you can eat. Though, I don't know how well those are gonna save. They should probably wrap those in like a napkin or something. Anyway, take a close look at that overturned backpack and you'll notice that it looks somewhat uterus-like. Methotrexate can be used for the termination of intrauterine pregnancy in conjunction with misoprostol. It inhibits trophoblast cellular division, thus decreasing trophoblast survival, hindering implantation, and encouraging expulsion. Methotrexate is also the drug of choice for the non-surgical treatment of an early, unruptured ectopic pregnancy. That's because folate antagonists are effective in hindering the growth of rapidly proliferating cells in developing embryos. See that little baby keychain clinging onto the outside of that uterus? It's just like an ectopically implanted embryo. Aberrant fertilization events can also lead to gestational trophoblastic neoplasias, including trophoblastic tumors, choriocarcinoma, and invasive molar pregnancy. Each arises because of an abnormal proliferation of trophoblastic tissue, and most low-risk patients can be cured with a short course of methotrexate chemotherapy. So as she makes room for those purloined methotrexate meat sticks, a little mole stuffed animal falls out of her backpack as well. Kind of like the termination of an invasive molar pregnancy, if you will. And you probably should. Just trust me on this one. You know, these sketchy medical videos reach a wider audience than you'd think, including droves of young preteen fans. I mean,
What?
we're like the teen idols to them. That's why they call me Jordan Knight.
For what would they be?
Oh, is that too outdated?
Anyway.
Kirk Cameron? Anyway, we try to set a good example, and that's why we've added this totally rad protective equipment to these skater punks. Wait a minute, silvery scale on extensor surfaces? That can only mean one thing: psoriasis. Psoriasis is a common chronic skin disorder most commonly characterized by erythematous plaques with silver scale and hyperproliferation of the epidermis. So, proliferating cells, we can use methotrexate, right? Yes, and it's also effective for the treatment of psoriatic arthritis and psoriatic nail disease. Initially, the mechanism of action was thought to involve the anti-proliferative effects of methotrexate on rapidly dividing epidermal cells, though more recent evidence supports the concept that it's actually the immunosuppressive effect of methotrexate that controls psoriasis. That's right, neoplastic cells aren't the only rapidly dividing cells targeted by this antifolate agent. Methotrexate also effectively inhibits the proliferation of immune cells and is therefore used to treat a wide range of chronic inflammatory conditions. You see that lantern we've sketched in above our methotrexate meat chef? The design should remind you of a joint. Not only that, the flame sitting inside should remind you of the inflammation associated with rheumatoid arthritis, or RA specifically. This symbol is actually going to show up throughout this unit whenever we want to highlight the immunomodulatory agents used in the long-term management of RA. The foundation of long-term therapy consists of disease-modifying anti-rheumatic drugs, or DMARDs, DMARDs, including methotrexate, sulfasalazine, hydroxychloroquine, and TNF-alpha inhibitors. These agents inhibit the proliferation of immune cells responsible for the chronic inflammation and long-term joint destruction that eventually leads to disability. On your exam, a typical clinical scenario will involve a middle-aged woman with swelling, pain, and morning stiffness in multiple joints for more than 6 months, as well as some other characteristic systemic symptoms. Methotrexate is the preferred first-line disease-modifying treatment for most patients with moderate to severe RA, though response to DMARD therapy typically takes weeks. Short-term treatment with anti-inflammatories like glucocorticoids or NSAIDs can provide temporary relief of symptoms, but they do not provide adequate long-term control of disease or prevention of joint deformity. For that, methotrexate is often your go-to agent. It doesn't stop there, though, because methotrexate's immunomodulatory effects are useful in the management of numerous other chronic inflammatory and autoimmune disorders such as IBD, lupus, vasculitis, and dermatomyositis. So we've included a few antibody-evoking lanterns as well, torn in order to highlight methotrexate's ability to suppress the immune system. All right, let's talk side effects. When methotrexate reaches the systemic circulation, it causes death of all rapidly dividing cells, leading to a characteristic set of adverse effects that you are more than likely to run into on your exam. First off, remember that methotrexate is a folate analog that directly binds to dihydrofolate reductase, inhibiting the body's ability to regenerate the active form of folate, tetrahydrofolate. This can lead to a state of folate deficiency, as evidenced by that foliage that tumbles to the restaurant floor. And this can cause megaloblastic anemia, which is a form of macrocytic anemia in which nucleic acid metabolism is impaired, leading to reduced efficiency of cell division and nuclear cytoplasmic dyssynchrony. Our recurring symbol for megaloblastic anemia? A megablast of fireworks, of course. With higher doses of methotrexate, myelosuppression becomes the major dose-limiting side effect. This can manifest as pancytopenia, kind of like this bone-shaped pan of sushi getting dumped by our careless waiter here, evoking that bone marrow depletion. Peripheral complete blood counts should be monitored regularly in patients on long-term methotrexate therapy. Methotrexate can also cause pulmonary fibrosis. Notice that bonsai in the back there depicting a fibrotic, though meticulously cultivated pair of lungs. Pulmonary fibrosis presents with gradual onset dyspnea, first with exertion and then progressing to symptoms at rest. PFTs will show a restrictive pattern of lung involvement, kind of like the restricted growth of this bonsai. You'll see decreased lung volume, decreased FEV1 and FVC levels, a normal-ish FEV1 to FVC ratio, and a decreased diffusion capacity. If you're given a chest x-ray, you'll probably see bilateral diffuse patterns of small, irregular opacity, most pronounced in the lower lobes. Just think of those tiny scattered bonsai leaves. And microscopically, progressive fibrosis can lead to dilated bronchioles that later coalesce to form that classic honeycomb appearance found in advanced disease. Methotrexate can also cause hepatotoxicity as depicted by that greasy liver-shaped stain left behind after a long day of meat stick handling. Hepatotoxicity due to methotrexate probably results from direct damage to hepatocytes. Minor elevations in aminotransferases are common, but hepatic steatosis, fibrosis, and even cirrhosis could occur. LFTs should be monitored routinely in patients on long-term methotrexate therapy. We're not done yet because methotrexate is on a rampage, destroying every rapidly dividing cell in sight, hair follicles included, leading to alopecia. And
That's why he's bald.
mucosal cells too, leading to stomatitis or soreness of the mouth. Whoa, that's fresh off the grill, man. You can't just poke a meat stick in your mouth like that. You better check your mucosa before you wreck your mucosa, friend. Do you see that figurine in the back there? That's a maneki neko, literally meaning beckoning cat. It's a common Japanese figurine which is often believed to bring good luck to the owner. In this sketch, this lucky feline symbolizes leucovorin, a special reduced form of folate called folinic acid. Think felinic acid. Leucovorin is used to reverse the toxic effects of methotrexate, especially bone marrow, GI, and mucosal-related toxicity. This is called leucovorin rescue. You see, folinic acid does not require dihydrofolate reductase, the enzyme blocked by methotrexate. Furthermore, it displaces methotrexate from intracellular binding sites and restores active folate stores required for DNA and RNA synthesis. Folinic acid may also be useful for treatment of acute methotrexate overdose. Quite lucky indeed, little maneki neko. All right, let's, sorry. It's just so many dumplings, you know? I just gotta take a few jobs. Okay, I'm good. Where was I? Let's head back over to our man with the DUMP dumplings because I want to introduce you to the other anti-metabolite drug that blocks the folate cycle, 5-fluorouracil or 5-FU. Oh, it looks like his friend is about to burst from eating one too many dumplings as he waves his hand at him. Because he's full and waving those 5 fingers, he's going to be our symbol for 5-FU. 5-FU is a pyrimidine analog, which is why he has that hexagonal pyrimidine-shaped plate in front of him. It primarily functions to inhibit DNA synthesis via inhibition of thymidylate synthase. Remember, thymidylate synthase catalyzes the conversion of DUMP to DTMP as represented by that plate of dumplings converted to the pyrimidine-shaped plate containing chopsticks arranged in a T. Remember, that's T for thymidine. This whole process is accomplished by transferring over a carbon donated from that methylated tetrahydrofolate boat floating by, as depicted by our dumpling connoisseur here grabbing that little carbon sushi roll from the boat. Tetrahydrofolate in turn is converted to dihydrofolate, a boat with 4 leaves entering and a boat with only 2 leaves leaving. Well, in the body, 5-FU is metabolized by a series of intracellular reactions to its active form, 5-fluorodeoxyuridine monophosphate, or FDUMP, F-dump. F-dump forms a complex with both thymidylate synthase, the enzyme responsible for that carbon transfer, and that tetrahydrofolate passing by. And that's why our overly full 5-FU patron is covalently grabbing onto those chopsticks about to donate that carbon sushi from the tetrahydrofolate sushi boat. This complex stops the de novo synthesis of thymidine, which inhibits DNA synthesis. DNA synthesis is occurring in S phase, of course, so remember that the agents in this sketch are cell cycle specific. I mean, this is the world-renowned sushi phase restaurant after all. Other active metabolites of 5-FU inhibit cellular function and division in other ways. By incorporating into RNA as 5-UTP, it interferes with RNA processing and mRNA translation. Or by incorporating into DNA as 5-DUTP, it interferes with DNA synthesis and function. However, for your exam, remember its effect here on the folate cycle, blocking that thymidylate synthase. As you can imagine, once thymidylate synthase is blocked, DUMP has nowhere to go and builds up in the cell. And it looks like those extra orders of DUMP dumplings just keep coming, piling up behind our inhibited sushi transfer over here. Also, keep in mind that cracked cancer crab in the center of the sushi boats meant to remind you that all these drugs can be used in cancer chemotherapy. 5-FU specifically is the most widely used agent in the treatment of colorectal cancer. This agent also has activity against many other solid tumors, including cancers of the breast, head and neck, liver, pancreas, and even topically for basal cell carcinoma. Now, most chemotherapeutic agents are associated with acute GI toxicity like nausea, vomiting, and diarrhea. Certain agents, though, such as irinotecan and 5-FU, cause major cytotoxic damage to all those rapidly dividing cells of the intestinal mucosa, leading to loss of epithelium and severe diarrhea. I mean, just take a look here at our full 5-FU patron struggling to hold down his dumplings. Did he sit in something? Maybe Ponzu? I sure hope that's Ponzu. A variety of cutaneous complications can accompany the use of therapeutic agents such as methotrexate and 5-FU. This includes photosensitivity reactions, and what an opportune moment to take some sensitive flash photos. Remember that 5-FU is associated with a variety of other rashes and even hyperpigmentation reactions. By depleting thymidine and inhibiting DNA synthesis, 5-FU can also cause myelosuppression and an increased risk of infection. So don't forget about our myelosuppressed server in the corner, complete with that recurring immunosuppressed cane. Although that lucky feline, folinic acid, can be given with methotrexate to rescue the bone marrow and prevent toxicity to the GI tract and other mucosal cells, this is not the case with 5-FU therapy. Even with a fresh supply of tetrahydrofolate around, if thymidylate synthase is inhibited, you just won't be able to turn that DUMP into DTMP, no matter how hard you try. I mean, just look at that guy. So, as our full patron here backs away from the dumplings and succumbs to toxicity, he knocks one of the lucky felines onto the ground. Not so lucky this time, little Maneki Neko. Alright, there is one more drug that I want to mention that affects the thymidine synthesis pathway. I know, you're full, that guy's about to black out, and I'm barely able to contain my stomach contents right now, so let's take a few steps back from the DUMP dumplings. Remember that thymidine is a deoxynucleoside found only in DNA, not RNA. But the thing is, it's actually ribonucleotides that are synthesized first and then converted to deoxyribonucleotides used in DNA. So, the precursor to all those pyrimidine nucleotides is, in fact, a uridine monophosphate, or UMP, which is subsequently phosphorylated to uridine diphosphate, or UDP. UDP is represented here by the sign at the entrance. You dining in? Please sign in. UDP, it turns out, is the substrate for ribonucleotide reductase, which converts UDP to deoxy-UDP, a molecule that will eventually go on to form all those deoxypyrimidine nucleosides we need for DNA synthesis. And it looks like someone has signed in. Oxy, party of one? As the waitress crosses off the name Oxy and reduces the length of the list, think of ribonucleotide reductase, converting that UDP into its deoxy form. Now we're getting somewhere. Once we have DUDP, we can dephosphorylate it into those DUMP dumplings. And since the wait times at Sushi Phase can be, well, as the last Yelp reviewer put it, excruciating, why not enjoy the peaceful Zen garden fountain in the corner while you wait? A hydro rock area, if you will. The name hydro rock area should remind you of hydroxyurea, the chemotherapeutic agent that blocks ribonucleotide reductase. Notice how this mom here knocks over the ribonucleotide reductase waitress as she rushes over to get her kids out of that hydro rock area. Inhibited ribonucleotide reductase prevents the de novo synthesis of thymidine, which means DNA synthesis will be inhibited. This arrests the cell in the S phase of the cell cycle. That's S for Sushi Phase. As an anti-cancer therapy, hydroxyurea can be used to treat acute and chronic myelogenous leukemia. So remember too, that cracked cancer crab in the center of the restaurant to signify that all these drugs can be used in cancer chemotherapy. However, hydroxyurea can also be used to reduce veno-occlusive crises in sickle cell anemia. That's why we've included that Zen Garden rock rake in the back, suspiciously sickle-shaped. Through an incompletely understood mechanism, hydroxyurea increases the production of fetal hemoglobin, or hemoglobin F. Aw, he was only trying to get back that shiny coin from the fountain. Notice how the coin has a hemoglobin pattern engraved into it. Also, let that baby holding aloft this hemoglobin coin remind you of elevated hemoglobin F levels specifically. An increased percentage of hemoglobin F confers protection against the polymerization of the mutated hemoglobin S. Consider hydroxyurea in sickle cell patients with frequent pain crises. The side effects of hydroxyurea therapy are similar to the other agents. You've got your GI upset and diarrhea, and keep in mind that empty bone-shaped tray which represents that all these drugs at Sushi Fae's restaurant, including hydroxyurea, cause myelosuppression. Alright, let's sum up this sketch. At the Sushi Fae's restaurant, we outline the enzymatic pathways involved in the synthesis of thymidine, a pyrimidine nucleoside. UDP is first converted to deoxy-UDP by ribonucleotide reductase, which eventually ends up as those DUMP dumplings, which are converted to thymidine as depicted by those thymidine chopsticks oriented in a T. Remember, we're making pyrimidines here, which is why we've highlighted that characteristic hexagonal pyrimidine shape with the sushi plates. Hydroxyurea over at the Hydro Rock area inhibits that initial conversion of UDP to deoxy-UDP by blocking ribonucleotide reductase, while the full 5FU customer blocks the conversion of those DUMP dumplings to thymidine by blocking thymidylate synthase. Remember, thymidine synthesis is powered by that sushi boat folate cycle because thymidylate synthase grabs that carbon from tetrahydrofolate boat that passes by. After carbon transfer, tetrahydrofolate normally turns into dihydrofolate, which needs to be reactivated to tetrahydrofolate before the cycle can continue. Those methotrexate meat sticks prevent the conversion of dihydrofolate to tetrahydrofolate by acting as a folate analog, directly binding to dihydrofolate reductase and blocking its function. This can lead to folate deficiency as depicted by the foliage that falls from the counter. Megaloblastic anemia can result, so remember those megaloblastic fireworks. Methotrexate is also associated with pulmonary fibrosis, stomatitis, and hepatotoxicity, so measure those LFTs. Blood counts are also important too, because all the drugs in this sketch cause myelosuppression. Leucovorin to the rescue. This lucky feline reverses the toxicity of methotrexate, but remember, it has no effect against the GI distress and skin rashes caused by 5FU. Ugh. I really don't feel so good. If I even look at another one of those dumplings, let's move on to the next sketch starring the purine analogs.
Okay. That wasn't so bad. Interesting that it's interferons. Okay. And then after this, probably breaky time. Because attention span is dropping very rapidly. Hello. All right. But remember complete anatomy. What a time. There we go. The symbols. Okay, this one is not long. Not long. I love Sketchy Farm. Not more than Sketchy Micro though. Sketchy Micro was pretty fun. I still remember all those microbes. No, I don't. Mostly. Kind of. Whoever came up with Sketchy is actually the GOAT. Like, actually a genius. I can't believe it, like, I don't know how it started, but I'm assuming, like, some student made it, like, a project, and then, like, look at how big it's become. It must be, like, such a cool achievement to, like, imagine, like, applying to residency, and then you can say, yeah, I was the founder of Sketchy. Like, that's crazy. I'd be like, you're accepted immediately. Just, like, by how much sheer influence and help you have been to all medical students. It is truly amazing. An amazing achievement. I'm gonna search that up actually. Who founded Sketchy? They must be so proud. I wonder, like, if they get recognized or anything. Like, solely by their voice. I wonder who, like, the artist for all of this is, and, like, how the process works. Because they have to draw things, like, in layers sequentially, right? So that they can, like, make them pop up as the video goes on. So that must be pretty interesting. Pretty cool. I would love to see, like, the process of how a Sketchy is made. Low-key, like, the drawings are, like, kind of mid, but, like, the style is very distinct, you know? It's, like, very sketchy. Maybe that's why it's called Sketchy. Who is the founder of Sketchy? Founded by medical students Saad Sid, I'm not going to try to say, Andrew Berg, wow. Aw. The 4 co-founders, medical students at the University of California, Irvine. Wow. That's actually so fun. I wonder how, like, this started. Like, maybe they have to be very, like, creative, talented people to, like, come up with this idea. It's very cool. Wowza. So this is one of the founders. Oh. Very cool, very cool. My gosh. Got an interview? Kind of curious. Hello? Nothing is loading. Also, I don't know how loud my laundry is being, so. Oops. Hopefully it's not that loud. Let's just start.
Yes, the 1980s, the golden age of the arcade. Oh, remember the old coin on the bezel of the control panel to hold your place in line? The sweaty, yet comforting feel of the arcade stick after the previous player left the machine? Oh, remember the
I
high
don't
school
remember.
kids who would smoke and crowd the machines, not
actually
letting
don't
any of
remember
the
that.
young kids play? Yeah, I don't remember any of that either.
Oh.
I was born in 1987. The Super Nintendo was my jam. But let's pay
Real.
homage to those dark, smoky, and somewhat moist times together now. Welcome to the Interferon Arcade. No setting drinks on the control panel. No crowding the machines.
What was the other sketchy that was in the arcade? Oh, what was it? There was a sketchy in an arcade. Fuck, I'm forgetting. I don't remember. I can't remember. Shit. Well,
And we just got through the oil crisis and energy crisis of the 70s. So spend your quarters now before the inflation rockets even higher. Interferon are host cytokines that exert antiviral, immunomodulatory, and antiproliferative effects. In other words, when a cell gets infected by a virus, it releases cytokines, such as interferons, that bind to receptors on other cells, resulting in intracellular signals that activate an immune response. This includes modulating T cells, activating macrophages, and buffing up host cells against further infection. So in this scene, cytokines are cytocoins, the arcade tokens handed out by our obviously virus-ridden arcade manager, just like a virus-infected host cell releasing a cytokine signal. Upregulation of interferon synthesis in infected cells is accomplished by interleukins, and that's why our manager's name is Luke. Once they got a hold of these cytocoins, the arcade patrons can go to their favorite console and combat ghosts and space invaders to their heart's content, just like activated immune cells combating invading viruses, immune diseases, and even some cancers. Here's one of the patrons now at our first arcade cabinet, Pachyderm Man. This arcade will represent the clinical uses of interferon alpha. Notice the alpha symbols in the title on the marquee. When Pachyderm Man first hit arcades in 1980, it immediately became the newest gaming sensation. You better watch your back, Centipede. And reading books. This game features a yellow, hippo-shaped creature trying to eat dots through a maze while avoiding pursuing enemies. A hippo is our sketchy symbol for hepatitis. Injectable preparations of interferon alpha are available for treatment of both HBV and HCV infections. Sometimes you'll hear the term pegylated interferon, and this denotes preparations that allow longer available for treatment of both HBV and HCV infections. Sometimes you'll
Pegylated? Pegylated interferon.
hear the term pegylated interferon, and this denotes preparations that allow longer half-life and steadier concentrations, thus warranting less frequent dosing. Administration of interferon alpha results in numerous adverse effects, and is part of the reason for the development of new investigational hepatitis C treatments that can supplant interferon therapy as a regimen of choice. Before we get into side effects, however, there are a few more clinical indications of interferon alpha to mention. It's approved for treatment of several neoplasms, including hairy cell leukemia and malignant melanoma. Take a look again at the marquee. It features our pachyderm hero alongside two of his pursuing enemies. This amorphous black ghost-like creature, evoking an image of malignant melanoma, and this hairy creature, representing, of course, hairy cell leukemia. Interferon alpha is also approved for use in treating Kaposi sarcoma, a disease associated with AIDS and caused by HHV8. Our sketchy micro Kaposi sarcoma.
With wigs.
Oh my god. Now it
your
wants
words?
to load. Let's watch it.
Sketchy is the only reason that I actually remember
which bacteria is catalase positive, which bacteria is oxidase positive or oxidase negative. I could have never understood it without Sketchy Medical. And I'm so honored to have Dr. Saud Siddiqui here today with us, who is the co-founder for Sketchy. A very fun fact about Dr. Siddiqui is that I used to watch Sketchy videos back in my third year of med school, and I searched up that who is the founder of this product, and I found out that Dr. Saud Siddiqui, who is of Pakistani origin, is the founder, and I went back to school, and especially did it start.
Especially in the beginning was pretty difficult. It was like a difficult adjustment coming from, undergrad. There was just so much to learn, not enough time. And I think in the beginning you kind of spend a lot of time figuring out how you study.
Yeah.
Right?
Still
some
figuring it
people
out.
in class, some people don't. Write your notes, type do questions, flashcards, the textbook, whatever. Like you're kind of figuring it out. And so when we were in micro, we were still kind of figuring it out, right? And we kind of stumbled upon this way of learning where we started to use imagery, characters, symbols, sort of what you see today, characters around these microbes to help remember them. And really it was kind of a last ditch effort. So like we had an exam the next day, it was like the middle of the night.
Exam the
and we were
next day is crazy.
A few too many coffees deep, and we just started doing this, really. And the next day on the test, shockingly, it was actually the only thing we remembered. And so this started out really on pieces of paper and whiteboards. And it's something that we continue to do, something that we kind of would bring our friends in on and kind of show them these images that we were drawing. This was Andrew Berg, who couldn't make it today. He's traveling, but he was a friend of mine and also just kind of the same study group. So we were kind of doing this together. So that's like initially where it started. And I can actually, for this podcast, I could probably send you like some of those pictures. I actually have some, so you can like put it in here so people can see.
I can attach them
what it
here.
looked like. Yeah, they were.
Oh my gosh. That's crazy. This is Agalactiae, right? Strep B.
For like stick figures. So that was like the very
Holy
beginning of so like we weren't artists, so like we couldn't really draw. So we met our third co-founder, Brian Lemieux. He was also a classmate of ours. And one day we were all supposed to be studying at a coffee shop, and he was just drawing something on his computer, literally just board, and like it was like this very detailed picture of, I think, an elephant. And we were like, dude, we gotta tell you about this idea we have. And then he was actually studying a bit like that too. And so the three of us got together, and I think the three of our different skills kind of.
That's crazy. Like everything just came together for them. And they formed Sketchy. That's really, really awesome. Okay. Back to the Sketchy video. Oh.
Our coma scene took place at Kate's Posies flower shop. And Kate's Posies make a return here as the little posy flowers that Pachyderm Man can collect for points as he navigates the maze. We've incorporated this posy theme into the side of the cabinet as well. Also, take a look at the control panel where you'll see our patron's stash of tokens accumulated in a jar. Kind of like the pill bugs accumulated in our human papillomavirus Sketchy Microsketch. This is to remind you of interferon alpha's use in treating condyloma acuminata caused by HPV. Interferon alpha has also shown activity as an anti-cancer agent in renal cell carcinoma. So let's sketch in one of those classic claw machines. No arcade is complete without one. Take a look and you'll notice that we've latched onto a cute little cuddly cancer crab. Nice. Let our recurring sketchy cancer crab inside this kidney machine remind you of the immune system's important role for monitoring and combating certain cancers, such as renal cell carcinoma. Now let's talk side effects, which are numerous. I don't think you quite comprehend the impact Pachyderm Man had on the popular culture of the 80s. It spawned an animated TV show, toys, and even a hit pop song, Pachyderm Fever, which it looks like our patron is experiencing now, a little dejected after missing the high score yet again. Interferon alpha causes a flu-like syndrome, headaches, fevers, malaise, myalgias that typically occur within 6 hours after dosing. It occurs in over 30% of patients during the first week of therapy and typically resolves. In fact, chronic therapy results in a host of side effects, including neurotoxicity causing mood disorders and confusion, profound fatigue, tinnitus, retinopathy, pneumonitis. Just think of the worst flu of your entire life. Yeah, it's way worse than that. One other side effect highlighted on the screen is myelosuppression. Notice the maze Pachyderm Man traverses is the shape of a bone, and he's eating white dots inside, like some kind of ravenous bone marrow suppressor. This may be important when co-administering with other myelosuppressive drugs, such as zidovudine. Interferon alpha rarely can induce anti-nuclear and anti-double-stranded DNA antibodies causing lupus. So, we've included our recurring lupus wolf, this time as a cuddly stuffed prize. Alright, before you leave, you should check out 2 more arcade cabinets in the back, which will symbolize interferon beta and interferon gamma. Interferon beta will be represented by Beta Invaders, the classic space alien shooter. This is because interferon beta is approved for use in relapsing type multiple sclerosis. At Sketchy, we symbolize MS by referencing the CNS lesions classically described as separated by time and space. This is highlighted on the marquee with the slogan, "Combat lesions through time and space." Interferon gamma will be represented by Gamaga, another classic shooter, where you command the Gamma ship to take down approaching asteroids. These asteroids represent the granulomas of chronic granulomatous disease. Part of interferon gamma's mechanism of action may be to activate macrophages that are not otherwise able to form the superoxide species necessary for oxidative burst. And so the gamma defender causes these granuloma asteroids to burst. You know what? Not everything from the 80s is worth remembering. Yeah, I'm talking to you, Jerry Curl. So let's sum up this sketch into a few important points. Interferons are totally rad. They are host cytokines that exert antiviral, immunomodulatory, and anti-proliferative effects. Think of a virus-infected cell releasing cytokines like our virus-infected arcade owner, Luke, handing out our cytocoins. Remember, this upregulation of interferons is accomplished by interleukins. Interferon alpha is depicted at our first arcade cabinet, Pachyderm Man. Of course, our favorite pachyderm is a hippo, our recurring sketchy symbol for hepatitis B and C treatment. Interferon alpha can also treat neoplasms, such as the pesky hairy cell leukemia enemy and the pursuing malignant melanoma ghost. And don't forget, if you want the high score, you need to pick up all those Kaposi sarcoma posies that appear in the maze. On the control panel, the accumulated tokens should remind you of treatment of condyloma acuminata caused by HPV. And behind our patron, inside that kidney claw machine, our last clinical indication is embodied by the renal cell carcinoma cancer crab. Chronic interferon alpha therapy results in a host of serious side effects, including flu-like symptoms, neurotoxicity, fatigue, tinnitus. Just think of it as the worst flu of your life. Also remember myelosuppression as Pachyderm Man gobbles up the cells in that marrow maze. And you know what? Play for long enough and you might just win a cuddly lupus wolf to take home. At the Beta Invaders cabinet, you can battle MS lesions through time and space. And at the Gamaga cabinet, it's all about blasting away those chronic granulomatous asteroids. Alright, this place is like grody to the max. I know this totally bitchin' place across the street. Let's motor.
Oh, we did it. Okay. I feel like for a hot second there, I was like locked the fuck in. Like the Addy kicked in or something. And I was like, damn, I could study for like another couple hours straight. And then like now it's just gone. Like that motivation is not there anymore. So I might need to take a breaky before I can continue. But hey, we got through everything for today, and tomorrow, what did I say, this week is just a bunch of sketchy, so shouldn't be too bad. The pathoma was the hardest part for sure. All right, we may or may not be back, but